Good morning, good afternoon, and good evening. Welcome all of you to this live program at Orthopaedic Principles. Today, our guest of honor is Dr. Giancarlo Polesello from Sao Paulo, Brazil. Dr. Polesello graduated in medicine from the Federal University of Paraná and then completed his master's in orthopedics from the Faculty of Medical Sciences, Santa Casa de Sao Paulo, and PhD in orthopedics from the Faculty of Medical Sciences, again at the Santa Casa de Sao Paulo. He is currently adjunct professor at the Faculty of Medical Sciences at the Santa Casa de Sao Paulo and head of the Hip Affections Group. Dr. Polesello is Associate Master Instructor for the Arthroscopy Association of North America. He's a founding member of the International Society for Hip Arthroscopy and also a founding member for the Brazilian Association of Musculoskeletal Ultrasonography. Dr. Polesello currently serves as the president of the Brazilian Hip Society for the period 2020 to 2021. So today, it's my great honor to introduce you to Professor Giancarlo Polesello from Sao Paulo, Brazil. Over to you, Professor.
Thank you very much, Professor Gopalan, for the opportunity. I am sorry for some mistakes in English, but I will try to do my best. Thank you very much for the invitation. Let's start talking about my 20 years experience in treating FAI. In 1996, we started our curiosity about hypertrophy. In 1999, we effectively started our practice. And what we heard in that time, why you do this if you perform just one per year? There's no indication in the hip. It's impossible because there's no articular space. If you have space, it's not possible to observe an spherical joint. You need curved instruments, curved scope. It's not true. Today, we know that's not true, but in that time, it was very confusing. So in the hip, there is no enthusiasm in the beginning because it's really technically difficult. It's a deep joint. There is a thick capsule in most cases. No, there was no well-defined indications in the past. Today, we have very well-defined indications. There is a real neurovascular lesions risk, and it's real that you need special equipment and setup. When a knee surgeon performs 5 knee arthroscopies in the morning, we need one morning to perform maybe just 1 or 2. So it's much more demanding. There's a need for traction monitoring. The results were uncertain, and imaging methods in that time were insufficient. Today, we are much better in this subject. Many diseases today are well known, but before they were unknown. Even the FAI was unknown, and there was no treatment available in that time for FAI. So in that time we started, and it was very, very tough starting learning. And it was very difficult to learn. And I stopped it for almost 1 year, and I started studying why it was so difficult to learn. And I realized that there are learning phases in the life of whatever you will learn, even in other areas in your life, engineering, whatever. So in the beginning, you are unconscious that you are incompetent. So you don't know that you don't know something. This is good because you don't know anything. The problem is when you realize that you know that you don't know some technique or something. So this is a problem because you know that there's a lack of, you need something more, and you don't know that. The problem persists, and you start doing that, and you are now conscious and competent. You start doing that, but the problem is that you not do this automatically. or like you drive a car every day. When you get in your car, you start driving simply. You don't think in driving a car. So it's the same thing. When you reach the unconscious competence, this is the good thing. The problem is that these phases are always the same. And when you are conscious that you are competent, you start doing, you are more prone to mistakes. This is the problem. Because when you make mistakes in medical practice, you tend to stop it. Or if you have a complication, you tend to stop it. So to get the unconscious competence, you need to persist. This is the problem. This persistence between the conscious competence and the unconscious competence. This is the problem for everything that we learn in life. So the traction. So this may be quite simple today, but the traction technique, Dr. James Glick, that started this, realized during 7 years, this thing, just this eccentric force here that provokes eccentric distraction of the hip. He took 7 years to realize that he needed this eccentric pin to pull out the femur out of the socket. So today it seems very simple, but in the past it was not simple. 7 years for Dr. James Glick. Now, we can use an eccentric post or a central post. The main goal of this is always this vector of the traction that pulls out the femur in this direction and not in this direction. This seems today very simple, but it's not simple in the concept in the 70s. And so we in Brazil use very much this kind of foam that you put in the table, because many tables here in Brazil, we are just central posts and not eccentric posts. Today is more common eccentric posts, or you can choose between any technique. The portals, the most popular portals are the anterior, the lateral, and the posterior portals. I will describe here because they are very popular. They are very well known. So the ASIS, you draw a line through the patella and another through the tip of the trochanters. So there's a crossover here, and this is a point that that Thomas Bird described in his book. Another point anterior to the trochanter, another point posterior to the trochanter. Today we know that to avoid the neurocutaneous, the femorocutaneous nerve, we try to deviate this point a little bit distal and lateral to avoid the femorocutaneous nerve. But these three portals remain the main portals until today. So the basic technique, we start the lateral port, because they are this portal, this portal. The first one is distant from neurovascular structures. Afterwards, the anterior port under direct vision. Afterwards, the posterior port also under direct vision. And the fourth step is the lateral port criticism. We need to criticize this portal because it was blind. We established it blindly. So you need to critique this portal to know if you made some mistake, like perforating the labrum. So when you start, you look upwards and see the bubbles here. The bubbles indicate that you are looking upwards. The capsule, the labrum, the femoral head, and you see this triangle, and you will establish your portal, this space, trying to avoid the labrum and the femoral head. Looking posteriorly, you see the same triangle, the head, the acetabulum, and the labrum. You will put your needle, your guide needle, here in this triangle, and afterwards you remove the scope from this portal that you placed blindly, and see if you perform some iatrogenic portal mistake here. And this, in this case, is good. Okay, this is the basic technique. So the arthroscopic anatomy, we learned so much about the arthroscopic anatomy. The bubble goes up, so this is anterior. We operate on these patients in prone position. The femoral head, here's the femoral head, the triangle, the posterior triangle, the labrum, and the acetabular surface. Here is the needle. You always use the triangle. Be careful to not perforate the labrum. Here is the blind portal. It's okay. We didn't perform any iatrogenic puncture in the labrum. And you can start performing instruments or putting instruments and trying to rotate medial and laterally to see the ligamentum teres and the pulvinar arthritis and lesions, and you can start your diagnosis even extraarticularly, like the medial synovial fold, the femoral neck, the articulation between the head and the acetabular, the zona orbicularis is here, the zona orbicularis of the femoral neck here, and the articulation, the joint here, femoral acetabular joint here with some bruise in the labrum indicating some lesion behind it. So Dr. Mark Safran borrowed me this video showing the problem of the femoral acetabular impingement. When you have the impingement, the pelvic is a ring, and you have compensations around all the pelvic ring, and sometimes the patient comes to your office just with an herniated disc. So many times the first symptom can be an herniated disc, and this can confound the specialists, because many football players, including soccer players, they have like the first symptom, the ligamental knee ACL lesion. So the ACL lesion in some soccer players must be very well examined to find some limitations in internal rotation, because they are all related. So the physical examination is so important. And the arthroscopic examination shows in this case the problem. The problem is that if it passes through here blood, it passes the synovial fluid. And look what is the problem of the synovial fluid penetrating behind the bone and the cartilage here. So it will delaminate with the conflict between the femur and the acetabulum. It will provoke the delamination of the cartilage. We must think this. When you have this mechanism of lesion intact and almost the same mechanism, this patient will not get better with physical therapy. This is a progressive lesion, and we'll take all the delamination here. And when the delamination comes through to the weight-bearing lesion, weight-bearing area, this will be very bad for this patient. So I realized that I learned more with my mistakes than with my hits, and it stimulated me to study why hypertrophy fail due the indication, due traction, osteoplasty, healing, fail also because complications, inadequate rehabilitation, and I don't know why it failed, but I have an idea and I will show to you afterwards. Failed in the indication. Look, this problem in asymptomatic people for hips, cam deformity was diagnosed in 37%. In asymptomatic people, the pincer in 67%, labor injury in MRIs in 68%. Look, how many are the chances for you to misdiagnose people, even in another areas of the human body? So take care with this, because many patients have deformities asymptomatic. So be careful. The personal history of this patient, he was operated, it's in a case example, on his right hip in 2014, another surgeon in another city, and was reoperated by me with labor reconstruction in 2015. So I realized that here is an area of an osteoplasty of the femur, but I realized that the main cause of reoperation is inadequate osteoplasty. And I thought that it was an inadequate acetabular osteoplasty. And I performed here in the other side. You can see the difference between this osteoplasty, this right side and the left side. But it looked to me that the pain was persistent because of this acetabular. This is the commonest case. And I indicate another arthroscopy, like the alpha angle was corrected in the femur, but the acetabular was not correct. So I tried to indicate another osteoplasty to better perform the osteoplasty in this side, this acetabular side, and I did it. I did it in 2015, and the patient here with the different acetabular here, and afterwards you can see the difference between pre-op and post-op. It was okay. I really felt that I decompressed this hip, and I alleviate this FAI. Good, but the patient persisted with the pain, and what called my attention was excessive pain. This excessive pain, unproportionate pain. And in the physical examination, after 3 months of the surgery, the patient has the gravitas. This is a Brazilian doctor that works with soccer players in a football team called Corinthians here in São Paulo. And he described this test when he stressed that the abdominal muscle against the adductor, there's a common tendon here. And when the patient tried to flex his abdomen and stress here the adductor, the pain can generate pain in the symphysis pubic. And I performed his technique to release the rectus and the adductor conflict between the rectus abdominal and the adductor tenotomy, intersymphyseary discectomy, curettage, macrofractures in the symphysis, and drainage. This is the original technique. I modified his technique, operating in the front of the patient with the traction table in maximal abduction without the post, and see the symphysis frontally. I modified a little bit his technique, and the patient was better. So I misdiagnosed his pain from the FII to the symphysis pubic, misdiagnosed. So this is important not to misdiagnose, and you can misdiagnose oppositely. The patient has pain in the hip, and he feels some pain in the symphysis pubic. So intuitively, to alleviate the osseous block and the soft tissue lesions in the hip, intuitively makes sense. However, the literature cannot assure that surgical intervention prevents the osteoarthritis and risk of a total hip replacement. And we know that it prevents pain, not the risk of osteoarthritis. So be careful. And this is an important random RCT work that was performed for the first group in Canada. At 2 years, reoperation rate was significantly lower after osteochondroplasty. So it's perfectly indicated that when you have a symptomatic patient, you relieve this conflict between the femur and the acetabular and repair the lesions caused between this conflict. So what's the learning curve for the hypertrophy? This is important to see that the learning curve is steep. This study more than 8,000 patients, 251 specialists. 5-year revision rate was, and the 5-year revision rate is much more for surgeons with less experience. So it's important. The very high volume, more than 500 hypertrophies per year, they have less complications. And the beginning of the slow down in the complication rate for the specialists, 12.3% less than this, are at least 389 hypertrophies. So there's a clear steep learning curve for this technique. We must be aware of that. And this for high volume surgeons, the complication rate and the reoperational rate is much less, like this in this case, 1% for high volume surgeons. So the experience affects the complication rates, and this is a systematic review for more than 2,000 articles, and just 15 articles were included. So one of these studies were our studies, my experience in this study that was published in the arthroscopy, shows that the complication rate when you start your learning curve, they don't get better. They just modify. When you start your practice, you start doing simple things, and afterwards you have complication because you start doing more complicated things in the joint. So be careful. So the conclusions of this, as the learning curve progresses, there are disease decreasing the complication rates. The surgeon and traction time is very important to be careful, and the reoperations are very common in this phase. And you need from 20 to over 500 to be expert, at least initially expert in this technique. The technical fail are due to traction, osteoplasty, and healing. Also are important to know. Closing the capsule, there's not enough evidence that you close the capsule. It's superior than close every capsule. Myself, with much patients, the athletes, that I close the capsule and I tight the capsule so much, I regret this, because many athletes of this, they could not return to sports asymptomatically. So be careful to patients that they need laxity to do very well their sports. And this work cannot suggest routine repair, and I do not suggest also. In the revision matter, systematic review, meta-analysis, revision arthroscopy improved, but not so much as the primary. So your golden chances in the primary surgery. And almost the reoperation, almost majority of the reoperations are for incomplete osteoplasty, 5 to 14% revision rate. And then the revision after labral reconstruction is more common in the female, with 2 more surgeries before reconstruction. 14% of these people needed a total hip replacement, and 7% adhesions. So this is a very high number of reoperations after reoperation. So we need to try to avoid the reoperation. In those that did not fail, the results are similar to those that did not needed revision. So a good reoperation is good for the patient. And adhesions and residual impingement are the most common findings for these patients. And another systematic review, 348 cases in 5 studies, the residual FAI is the most common case, like that case that I thought that it was residual FAI. It was not. So you need to examine very well these patients to not misdiagnose like myself. 5% reoperations rate in 2 years, total hip or new hypertrophy. Another systematic review about revision hypertrophy and indication outcomes. 40-48 hips, residual FAI, untreated labral lesions or chondral lesions are responsible for inferior results, and 14.6% of these patients needed another procedures. Risk factors for another revision is in 80 years follow-up, 4% needed revision. The risk factors, age less than 50 years, most until 18 months after the primary procedure, and the risk factor, if you leave some impingement, this is a very high chance to have another operation, have another indication. After revision in patients with FAI, the clinical outcomes 1 year post-op, 5%, almost 6% of re-revision in 172 patients. 19 patients required another surgery, 8 new arthroscopy and 11 total hip replacement. So it's a high incidence of reoperation rates for this case. For revision hypertrophy, there is significant improvement in the reoperation, but less in those with the loss of articular space less than 2 millimeters. I try to avoid patients with less than 160 degrees of range of movement, the total amount of range of movement, less than 160 degrees, and less than 2 millimeters in space, in articular space. Better in those with good articular space, like we said. Without previous level, good reports, they are better. Catheter application in the revision, there are better results as this study. My experience is not just the same, but the experience for the surgeons are one. And for the payers, the insurance payers are another. Be careful. 18% of complication rate for the payers, private payers. So you must estimate that the complication rate must be between 5%, because the surgeons tend to be more conservative in their complications, and the insurance payers tend to be more aggressive in his numbers. So it is the real number must be between 5 and 20%. It's alarming, much more than published, like this study. Age more than 40 years, smoking people in osteoarthritis, and this article calls attention for patients with psychiatric disorders, depression, and anxiety. Patients are more prone to lower results, high rates of reoperation and failures in this group. Fail due to complications, it's also a problem. Anchor articular penetration. Like this case, was not possible. The surgeon who was operating not to see this anchor in the joint, but he thought, oh, this is observable, very light, no problem. Let's leave this anchor here. In the reoperation, this is not true. The anchor here and the big lesion in the articular surface, in the acetabular surface, and in the femoral surface. So do not leave anchors in the joint thinking that it will be observable. Another case, it's a courtesy. Most of these cases, there's a courtesy of some colleagues throughout Brazil. This 6 months in the 24-year sportsman, and he started a big synovitis and painful hip 6 months after the surgery. And when the surgeon, Dr. Fabio Moria from Pará, it's a state from Brazil. He studied the macroscopic difference between the shaver blades. It's not, you almost can't see anything. But when you see in the electron microscopy, you see the difference between this national shaver blades and the imported shaver blades, better quality material. So to use better materials are also a way to have less complications. Other complications, heterotopic of ossification, DVT, neurologic and cutaneous lesions are common. So be careful with the scrotus, neurologic and cutaneous lesions like this, necrosis. Fortunately, this heals. Like this case, sometimes you have these complications, this heals very well, but be careful. In this case, the patient was not so lucky, because Dr. Ricardo from a city from Minas Gerais, a state in Brazil, was operating in a urological hospital. And in the urological hospital, they use water, not saline solution, for irrigate the joint. And he didn't realize that until this complication. And it ended like this in a huge necrosis of the soft tissues. Fortunately, he with plastic surgery helped the patient to heal all the scars, but it was a very bad complication. So be careful, even in the kind of solution that you irrigate your joint. It's my case. This is my case. People in the hospital didn't say to me that the saline was in a high temperature. I just realized after I felt with the gloves, 2 gloves, it's impossible to feel. And afterwards, it was late. The patient has this complication. Unfortunately, he's doing well because of the surgery, but the skin here was compromised, unfortunately. Rehabilitation failure. You have phases in the protection. In 6 weeks, maximal protection. In the first 6 weeks, range of movement, recover, protect soft tissues, avoid muscular inhibition, normalize gait. Phase 2, we always respect these phases. In 12 weeks, the gait reeducation, range of movement progression, muscular strengthening, functional independence after 12 weeks, and we progress to the phase 3, 16 weeks afterwards, neuromuscular control, aerobic activities like in the treadmill, bicycle, and swimming, proprioception and balance, painless recreational activities. In more than 20 weeks, we started putting these patients, not professional, because the professionals, we need to accelerate this protocol. We return to sports exercise, gestures, correction of muscular compensation that are very common in this kind of patients, strengthening speed and agility, proximal and distal body integration, plyometric exercises just after 20 weeks. And in phase 5, active sports after 24 weeks, painless sport activity, no muscular compensations, adequate range of movement, symmetric strength. We use much dynamometric evaluation of the strengthening and the power of every muscle around the hip. It's an important tool for us, the dynamometric evaluation after 24 weeks. And I perform in the athletes yearly this examination. And the patients answer to this satisfactory functional scoring like IHOT 33, Hagel's HOS, and the modified hip score. I don't know what failed, why it failed, but I have an idea. Like that article that showed that paper, so depression or anxiety in 35% of the patients in this database. For patients undergoing hypertrophy, it raises the cost before and after the operation. So be careful and with the history of depression and anxiety. And these patients, it's much more common with disproportionate pain. Today I am very careful with patients with disproportionate pain. the pain of the normal pain of these FAI patients are a pain. The hip is painful, but it's not disproportionate. When it's disproportionate, call attention, red light, because this is a problem. Maybe the patient has another problem, and you probably will be the responsible for another problems that not his hip pain. Be careful. So what I've learned in 20 years treating FAI, learning hypertrophy is not so easy. Open surgery is possible, but impractical due to big scar in a country, in a warm country like Brazil, plenty of beaches. The woman, especially the women, they do not simply accept a big scar in their hip. There are phases in learning, so the persistence is important. Do not treat imaging, treat patients. Today, I observe in Brazil, the first indication is the imaging. The history and the physical examination are secondary, and it must not be like that. The history in the first place, physical examination, and afterwards, the imaging in sequence must guide your indication. Be careful with disproportionate pain, like I said. Reoperations are much more difficult than operations, and there's still a lot to learn. That's my practice and my conclusions after all this time. Thank you very much for this opportunity. Thank you, Professor Gopal.
Thank you, Professor, for that brilliant talk and sharing your experience of 20 years while treating FAI patients with hip arthroscopy. Few questions from our side. Do you think broken instruments are a common problem?
No, for me, well, as you have experience in manipulating tools into the joint, for me, more than 15 years ago, it was the last one that I broke in the joint, and it was a guide wire, needle guide wire that I didn't pull out of the joint, and it hit. The guide wire hit the pulvinar, hit the acetabular fossa, and I pushed the instrument, and it broke in the needle guide wire into the joint. This was the last one, and I learned this. I will put this in this talk because it's important. It was the last one more than 15 years ago.
Thank you very
much. You
just
want to learn. Huh?
Thank you very much, Professor, for that. And Prof, we have a lot of young surgeons on our channel who are just going to start a hip arthroscopy. So what would you advise them? For example, would you advise them to start with a lot of knee arthroscopies, go to shoulder and then hip? Or would you request them to go to do cadaveric workshops? Because you have a very vast experience in hip arthroscopy. So if someone wants to begin hip arthroscopy, how would you recommend them?
Yeah, I tried to start in the shoulder and in the knee with my colleagues in Santa Casa, in my hospital. But they use another joint with another scope, 30-degree scope, and we use 70-degree scope. For people that started with the knee and the shoulder, it's good because you know how to triangulate, but the anatomy and the scope, the scope angle is different. So I started directly from, I have never do open surgery, mini open and arthroscopic surgery. I started arthroscopically in that time because it was a request of my department to somebody needed to do something even without indications, you know. And I started to do that straight in the hip, straight in the with no indication of FAI before the FAI concept. So I don't regret that. It's good if you learn. You can learn in this way, and I recommend today. In that time we didn't have that. We have the ISHA, International Society for Hypertrophy, with many centers of training around the world. We have many specialists that can receive people to show their practice. We have the ANA courses, Arthroscopy Association of North America, plenty of beautiful and big courses. cadaveric practices like in Arthrex in Naples, Florida. We have the Smith-Nephew centers. We have the Stryker centers. Today we are planned the Zimmer centers. We are even the ConMed centers. We have plenty of tools and plenty of centers to learn different from the past. This is very good for people who wants to learn this technique.
Thank you, Professor, for that. And again, as I said before, we have a lot of young surgeons who want to learn. And if they want to be a part of the ISHA group, International Society of Hip Arthroscopy, how is it? Is it a membership annually, or is it a life membership? And how much is the approximate cost? And suppose they want to learn hip arthroscopy, what are the centers? If you can give just a short overview, because a lot of people keep inquiring on how they want to learn hip arthroscopy.
I think if you put in the Google browsing ISHA, International Society for Hypertrophy, they have more information there. There are different levels for students, specialists. So go through the ISHA website and to the ANA website, aana.org in the United States, and go to surf in the web a little bit. You will find many information. It's cheap to have access to specialists, many specialists like me. I was taught by Thomas Bird. Thomas Bird has 2 or 3 editions of his book. It's a beautiful book. And I once asked him, why you teach me so good, and why you are so kind with me? And he said, for you to be the same thing with another people in the future, So that's why we must be kind with people that want to learn this technique,
Thank you, Professor. I think that's all the questions that we have for this session. Fantastic lecture, Professor. And I'm sure this lecture is going to benefit a lot of people all over the world. Thank you so much for joining in.
Thank you so much, Professor. Thank you so much for the opportunity. And I am here, whatever you need from me or from my colleagues in Brazil. I am the president until the end of this year, but I have some influence in this Brazilian Hip Society. And if you need our participation in other events, we are very happy to contribute with the science and with the hip development. Thank you very much.
Thank you very much.
Okay. Thank you. Have a nice day.